Hello, GvHD Hub viewers. My name is Erik Thiele Orberg. I'm a clinician scientist at the Department for Hematology and Oncology at the University Hospital Rechts der Isar here in Munich, Germany. Today, I've been asked to talk about how we can use metabolites to prevent graft versus host disease after allogeneic stem cell transplantation, and it's my pleasure to contribute to that topic. So, what are microbial metabolites in the first place, you may ask? So these are small molecules that are the byproducts of bacterial metabolism. For example, we are interested in the metabolite named DAT, or des-aminotyrosine. This is produced by a bacterium called Flavinofracter when it metabolizes flavonoids, a nutritional compound typically contained in coffee, tea, or red wine. In other words, in the intestines of healthy individuals, flavonoids are being converted to bacterial metabolites. And that's where we then believe that they can act, and specifically on the epithelium and its epithelial cells and intestinal stem cells, and where they can contribute to the regulation of intestinal regeneration, but also to mucosal immune responses. So then I think you may ask yourselves, why are metabolites relevant in graft versus host disease? So I'd like for you to recall that the composition of the microbiome predicts mortality in allogeneic stem cell transplant patients. It's actually a very solid determinant of outcomes. And here in Munich, in our own patients, in our own bone marrow transplant unit, we have made the same observation, namely that GvHD patients suffer from a very low microbial diversity and often an outgrowth of detrimental bacteria such as enterococci. But, and this is important, bacteria are not only detrimental, there are a plethora of protective bacteria. And so the questions we asked ourselves was, are microbial metabolites responsible for conveying the protective effects of the microbiome to patients? And could the poor outcomes that we observe in GvHD patients be explained by a loss of protective metabolites? So together with my mentor Henrik Pöck and Ernst Holler from Regensburg, this is another university hospital not far from Munich, we looked at microbial metabolites in patients across our two bone marrow transplant centers. And we made the observation that most patients had really diverse and abundant metabolite profiles going into their allogeneic stem cell transplantation. But those that developed GvHD all but lost metabolite production. Currently, we're in the process of establishing whether metabolite levels at baseline can predict the occurrence of GvHD. So the final question then that remains to be answered is, how may we be able to use metabolites in clinical practice? As you may know, one promising method to treat severe graft versus host disease is FMT, also known as stool transplantations. We actually performed this procedure at our center and noted that we could restore metabolite levels in the recipient patient. However, FMT is on hold indefinitely in Germany due to concerns that COVID-19 could be transmitted via this procedure. So I think this is where metabolites come in. They are small molecules that can easily be synthesized and may offer the same benefit of FMT without concerns for transmitting infectious diseases. Therefore, we envision that either individual metabolites or metabolite cocktails could be administered prophylactically to our patients undergoing stem cell transplantations. Of course, this would have to be done via clinical trials to definitively show a benefit for patients. If you'd like to find out more about how metabolites act on the epithelium, I invite you to view my presentation at this year's EBMT annual meeting. And with that, thank you for your attention.